So good morning, everyone. My name is Akarin Hiransuthikul, and on behalf of all co-authors and all the study staff, I'd like to thank the conference organizer for the opportunity for us to present our first finding from our study, the iMACTStudy study. And for those who had a chance to come yesterday to the abstract debate session, you may notice the similarities between the two studies. Today is the iMACTStudy study. Yesterday, I presented the APACC studies. And as the name suggests, for yesterday's study, that was the third APACC study, and which means that it was the third drug interaction study among transgender women that we conducted in the RHI Bangkok, Thailand. Today is our very first drug interaction study among transgender men that we conduct in RHI, and we are thrilled to have a chance to share the first result with you. Some disclosures: this study was supported by an investigator-sponsored research grant through Gilead Science. Concerns over drug interactions between gender-affirming hormone therapy and PrEP is still there and may have limited the uptake of PrEP among transgender individuals. Now, unfortunately, information on PrEP among transgender men is greatly lacking, including the thing that we are focused today, the potential drug-drug interaction between masculinizing hormone therapy and PrEP. The big picture of our study, iMACT for short, was to investigate whether there are actually any drug-drug interactions between oral daily PrEP and masculinizing hormone therapy among transgender men. And because this is our first study, we came a bit late compared to the IFAC. That's the reason why we want to explore both components of PrEP, FTAF and TDF FTC as well. For the pharmacokinetics parameter for PrEP assessment, we assessing 4 components: plasma, PBMC, urine and rectal cervical tissue. Now, unfortunately, all these results for PrEP is not available right now. We are eagerly waiting for the result, which is expected to be within the 2 months. But today, however, I have a chance to be able to talk about the potential impact of daily oral PrEP on the hormones. And the marker to be used is plasma total testosterone. So for the iMACT study, 40 HIV-negative transgender men who had not undergone oophorectomy were enrolled last year. The study drugs, I think this is very important for our study, is that all participants were given the same hormone regimen, testosterone inactive 200 milligram intramuscular every 2 weeks. As mentioned earlier about the 2 components of PrEP, randomized in a 1-to-1 ratio fashion to receive either TDF-FTC or FTAF. Now I want to shift everyone's attention to the right-hand side of the screen to look at the iMACT study scheme, because I think this is very important before we move on to the results. Whether it's iMACT study, this one, the first IFAC, the second IFAC that we had conducted half a decade ago, or yesterday's IFAC3 study, we all have the same concept, and that is two-way analysis. And what I meant by that is we are not just investigating the impact, the potential impact of PrEP towards hormones, but also vice versa as well. And how we achieve that, I would say kind of like a modified crossover study design. And what we did was that we started hormones at the first visit, wait for it to reach its steady state. For this study is 4 weeks. That 4 weeks measurement, hormones measurement, will be the level of hormone without PrEP. After that, we're going to initiate PrEP. Of course, after the PK visit for this study is taking quite long, 2 weeks. We start PrEP, wait for it to reach its steady state, which will be at week 12, and we do the second hormone measurement, and that second hormone measurement will be the levels of hormone with PrEP. And basically today, what I'm going to present is comparing between week 4 and week 12. Week 4 again, hormones level without PrEP. Week 12, hormones level with PrEP. We do that in a similar fashion for PrEP assessment as well, but in opposite direction. So the first PK measurement for PrEP at week 12 will be PrEP level with hormone. After that, we discontinue the hormones and then do the second PrEP measurement at week 16. That will be the PrEP level without the hormone. And we're going to compare week 12 and week 16 to measure whether there are any changes in the PrEP. Unfortunately, as mentioned earlier, the data is not here yet. So for the results, the data was available for 11 participants, 6 from TDF-FTC arm and 5 from the FTAF group. For TDF-FTC, median age of 31, median BMI of 24.8. For FTAF, median age of 27 and median BMI of 24.9. Now moving on to the primary results. For starting off with the TDF-FTC group, you can see here that we're going to compare week 4 and week 12. Once again, week 4 is hormones level without PrEP, week 12 is hormones level with PrEP. And you can see that across all PK parameters, whether it's AUC, Cmax, C-throw, there seems to be no significant differences between the 2 weeks. This is for the TDF, FTC group. Seems to be no significant difference in the hormone level. Moving on to the FTAF group, I want to have everyone look at the concentration first, the Cmax row and C trough row. Similarly to the TDF FTC results, no significant differences. Now, the statistically significantly differences relies on the AUC or the exposure, as you can see that, and the AUC column or the exposure of the hormones. There seems to be an increase, statistically significant increase for around 10% when you look at the GMR once PrEP was initiated. So in conclusion, there were no statistically significant changes in plasma total testosterone concentration when masculinizing hormone therapy was co-administered with and without PrEP. Plasma total testosterone exposures, i.e. AUC, was statistically significantly higher when FTAF was with the co-administration of FTAF, but with this 10%, I would say clinically significant is not expected. Last but not least, all of PrEP assessment, the plasma, urine, PBMC, and rectal and cervical tissue are ongoing, and we are expected the result within the next 2 months. I would like to thank all our participants for their dedication in participating in the study, and to all the study staff for their tireless effort in taking care of all participants. Thank you very much.